with roll call, please.
Senator Rocky Adams. Senator Chambers Armstrong.
Here.
Senator Berg. Senator Carroll.
Here.
Senator Douglas.
Present.
Senator Elkins.
Here.
Senator Funky Fromeyer.
Present.
Senator Nemes.
Present.
Senator Tishner. Senator Wise. Representative Bentley. Representative Bratcher.
Present.
Representative Bray. Representative Burke.
Here.
Representative Callaway.
Present.
Representative Dotson. Representative Duvall. Representative Frazier Gordon.
Yes.
Representative Justice. Representative Neighbors. Representative Palumbo.
Here.
Representative Raymer.
Here.
Representative Riley. Representative Rourke.
Here.
Rorke's, sorry.
Here.
Representative Sharp.
Present.
Representative Weber.
Present.
Representative Wilner. Representative Witten.
Here.
Co-Chair Mosier. Co-Chair Meredith.
Present. Again, we do have a quorum and duly constituted business here. I would ask to make sure that you've got your phones on silent if you haven't done that already, so we can keep this meeting running as smoothly as possible. You see, we have a very full agenda today, and we'd ask our presenters please be as concise as you can possibly be. Immediately following this meeting, we have Veterans, Military Affairs, and Public Protection Committee meeting that'll be next door. Several members of this committee are on that, so we want to make sure we finish in plenty of time. With that, our first, before I do that, let me recognize a couple of new members, and that's Senator Greg Elkins. Senator, glad to have you with us. And not new to the legislature, but new to this committee is Representative Ruth Ann Palumbo. Glad to have you both this morning. And obviously, Representative Palumbo is replacing the late Representative Blayman Swan, who passed away. We could just have a moment of silence in memory of him, if you would, please. Thank you. Our prayers are certainly with his family. Our first order of business is the ending of the federal COVID-19 public health emergency. If our presenters are here, I'd ask you to come forward. I think if everyone's familiar with this agenda, you'll see this whole meeting is kind of focused upon what's happening post-COVID.
Good morning. I'm Eric Friedlander, Secretary of the Cabinet for Health and Family Services.
Good morning.
You need to turn it.
My husband would love one of those buttons at home. I'm Connie White. I'm the Deputy Commissioner for Clinical Affairs for the Kentucky Department for Public Health.
Glad you have you both with us this morning. If you would, please proceed.
Thank you very much. Before we begin this presentation, there are a couple of things I'd like to talk about, two pieces of good news and one piece of bad news. First is we have selected the new commissioner for the Department of Community-Based Services. Acting Commissioner Lisa Dennis has been promoted to be the commissioner. Lisa, many of you know her. She's testified numerous times in front of different committees. She brings a wealth of experience, lived experience. She has actually had positions and grown up and come through the Department for Community-Based Services all the way from the local level to the regional level to the state level. I'm very excited that she's agreed to be the commissioner, and hopefully she will bring some real implementation to some of the things we've been talking about, some of the new things we've been doing, and I believe that she'll bring a stability to the Department of Community-Based Services that will be very helpful to the department. Secondly, the Department for Behavioral Health, Developmental, and Intellectual Disabilities, and yes, that's one of the longest names in state government, and it's my fault because I named it when I was there. Dr. Katie Marks, who has been leading Kentucky's core effort, the opioid effort on reduction, actually began under the Bevin administration, and she is agreed to be the Commissioner of Behavioral Health. She will bring, I believe, change to the department, a new perspective to the department. Her experiences in substance use. She also has a background in behavioral health and will be learning parts of the developmental and intellectual disability world, which I'm very excited for her to be there. She brings an energy that I think, again, some of you have seen her testify, and I believe a level of competence has me very excited that she will be joining us. But that leads to the bad news, which is in the field of folks with developmental and intellectual disabilities, our home and community-based waiver slots are now full. First time ever for all of our waivers to be full. I think there are 2 tiny waivers, acquired brain injury and Model 2 waivers that don't have waiting lists, but everything else does, including what is primarily the long-term care waiver. It's called home and community-based waiver. There are over 17,000 slots. For the first time ever, those slots are full. In August, we begin a new waiver year, and it's a lot of federal jargon, but we'll have some slots open up, but it'll be a brief period of time. We'll be coming to the General Assembly during the next budget session, I'm sure, and requesting more slots. It's how these the slots are allocated each year and in the budget each year. And so we will be asking for more slots for more folks. This waiver in particular, and what we, I think, have to address, and I'd be happy to address this in a full committee hearing, but I just wanted to let you all know some of the challenges we have around children. And we've had some of our first public kind of forums on a children's waiver. And these are all really, really complex issues, and I'm sure we could have an entire meeting or 2 or 3 on waivers alone. So I wanted to put that out there for everybody to know. I'm really excited about the new commissioners. I think having that leadership in place will be very helpful, particularly heading through some challenging times, which we all know we're going to have. So thank you for that, Chairman Meredith. I did want to let folks know that up front.
Thank you, appreciate that. And just to follow up your conversations about the waivers, I think certainly that does warrant a separate, probably full meeting on this. Still working with Representative Moser to develop our agendas for the balance of this year, but certainly the waiver programs are very important to us and something that all of us have a lot of interest in. So we will commit some time to that in the future, I'm sure, but I appreciate that.
Yeah, and I'm available anytime folks would like to come, or if they like individual meetings, I'm happy to do that as well, as always, as you know.
Thank you.
And with that, I'm going to turn it over to Dr. White.
Good morning, everyone. Thank you for asking me to come today. Dr. Stack had a family obligation, and so he asked me to come in his place. One of my joys of the job that I do have is I get to fill in for the commissioner whenever that happens. And I'm happy to talk to you today about what's happening in public health with the ending of the national public health emergency. So our federal emergency, as you know, the emergency ended in May, and our federal grants are starting to run their course. We have some that are ending at the end of this month. We do have in disaster response, health equity, and laboratory. Some of them have been extended another year, so they will end in June of 2024. But most of that extra COVID funding that's been coming our way as a department will end the end of this month. We, as you know, have done testing support across the state for the last several years, and now that support is really honed in on our long-term care facilities, about 300 of those in the state. Because of the particular vulnerability of that population, we want to assist those long-term care facilities in their ability to do testing. And so you'll see, as you've seen, public testing, those kinds of things have wound down as that funding has gone away. Our antigen test support is also starting to wind down. We will continue. We have worked in the past with K through 12. I've been very involved in the Kentucky Department of Education testing and making sure schools that were interested in having that testing is available. We've offered that through summer school this year. Some have taken it, some have not been interested, but we've done testing there. We have worked a great deal in our homeless shelters to be sure they have testing available, and we've worked very closely with corrections to be sure that testing is available. That's all winding down. So now we're going to be able to give our testing resources to our local health departments so they can choose how in their communities is the best way to use those testing, and continue with our homeless shelters and with corrections. So that's a relationship we had started building right before COVID started, and that relationship with public health and Department of Education is stronger than that has ever been. Most of the responsibilities for vaccines and treatment is going to transition to the public marketplace. As you're going to see, this is going to be an infectious disease that we will have routine approaches for. So you can get your vaccines just like you can get your flu vaccine, but it will not necessarily be free. It will be covered by your insurance program. Treatment, you see the commercials, you can get Paxlovid. Right now, the government has bought a certain supply, but when that depletes, it will only be available for uninsured in certain populations. But that will become a part of any kind of antiviral treatment that you need to get out in the regular healthcare community. Data collection and analysis function, we still are doing that, even though there's not a daily report. If you've been to the website, you'll see lots of changes. We are still continuing to analyze our data. This is the pandemic that there will be decades of research on this, and looking at slicing and dicing it in ways that we probably couldn't in real time because the pace was so intense. But we are changing the way we report, just as we report other typical diseases, and looking at our mortality surveillance. As our funding is going down, we're narrowing staffing as this enhanced funding goes away. But like I said, we'll be reporting this as we have reported other communicable diseases.
The overarching point, and you can go to the next one, it's fine.
Okay.
The overarching point here is we're really getting to an endemic stage. This is just going to be a regular part of our healthcare landscape from here on out, moving into the sort of the public regular commercial side on vaccines, on testing, on reporting. It's just an affirmation that we're headed into a new phase, and one that is more normal in terms of how we look at reportable diseases, communicable diseases. It really starts to just flow into our regular system.
So we wanted to go over with you some improvements that we have seen. I know Senator Meredith mentioned that in another committee. What have we learned? And that's something I think public health is very good at, is stepping back from a situation and we call it hot washes or after action look backs. What did we learn? What did we do well? And how do we want to improve? One of the good things that has happened, and I've been involved with this, I've been around for a while, not as long as the secretary, but I've been around for a while, and we've been working for years trying to get laboratories to do electronic reporting to KAHCF, the Kentucky Health Information Exchange, and this really jump-started that process. So we have had hundreds of clinics and laboratories are now onboarded with our Kentucky Health Information Exchange. And we've been able to use that quick access to that data in lots of different ways, not just with COVID. And so this really makes things go more efficiently and effectively. And so that is something that came out of the pandemic. Our Kentucky immunization registry has gone through lots of changes, again, changes that were planned but were put on steroids during this pandemic, even to the point that right now you can go to an online public portal and print out your own personal immunizations that have been reported to the registry. Now, if your provider didn't report it to the registry, we don't have it, but if your provider that gave you that vaccine reports that to the registry, you can access that yourself, and it's very easily accessible for your provider. In fact, many different providers put a registry button on their EHR, and so when you're in the office, they can hit that button and they know what you've had done. And so that certainly makes their work speedier and more efficient. So having that child and adult vaccinations there is extraordinarily helpful. Public health warehouses. We do a lot of things that aren't particularly flashy, and telling you that we're stocking gowns and gloves before the pandemic would be kind of a big yawn, but I think all of you that were here know that those stocks are critical So we've been able to expand our warehouse footprint, double at least, where we now have, and not only do we have stocks of the gowns and gloves, ventilators, other resources, but we have an excellent system for tracking that, to making sure that when someone asks for something, you go to the back of the shelf and get the stuff that's been there the longest, so that we're sure that everything we've got is current, it's crisp, it will be effective when it needs to be used. And this has been a big lift on our preparedness group, and we're extremely proud of that. As well as we've been able to, and I know this is on the next slide, but we've been able to set up some regional staging sites, which we were doing that in response to COVID, but the Secretary in his visits to Eastern Kentucky saw how critical that was, because we could send things to these regional staging sites for the people that were victims of the flooding this last summer. So having that equipment as quickly as possible to the people on the ground that need it is something that we are much more prepared for than we have been in the past. We've also, in our Division of Epidemiology and Health Planning, are pulling together a group that we're calling the Respiratory Illness Team, or the Respiratory Disease Team. And that team of epidemiologists and staff will be focusing on looking at things like COVID, like influenza. Influenza has been a problem in the past. So looking at influenza, looking at RSV. RSV is not a reportable disease, but we do have ways that we can get that data. There's a new vaccine for that coming out relatively soon. The last professional meeting I was at, there were banners everywhere about the RSV vaccine. So that's very exciting. So we've got a group that will be focusing their energies on respiratory diseases that is just now starting up. As I said, I've been around for a long time. I started with the Department for Public Health and Women's Health in 2009. So I've seen a lot of commissioners come and go, and a lot of health department directors come and go. And I do agree that I think our relationship as a unit is better than it's ever been in my time here. Local public health departments had we've heightened the perception of the local health department, and I think now we have, as Dr. Stack said before, we've got 61. We have a health department, a brick and mortar in every county in Kentucky, all 120 counties, but they're divided into 61 health departments. Several counties are grouped together in a district. So we have 61 health department directors, and we truly see them as the chief health strategist in their community. And that relationship has been quite stellar, and we are moving together, because prevent, promote, and protect, that's not just the Department for Public Health's vision, but that is Kentucky public health. All the aspects of Kentucky health in the state see prevention, promoting, and preventing and protecting is our mission. We have done some structural realignment of regional teams. So we have our structure at the state, but we have regional folks, and we've always had this, but we've been able to really enhance those relationships. So there is someone regionally that's looking at preparedness in a particular clump of counties, pulling together the hospitals and the healthcare providers and the dialysis centers and the dentists and all of the people that provide healthcare in those regions. So when there is a snowstorm, and we need to call because we need the local government to plow the road to get to the dialysis person that needs that. All of those things that most people don't think about. Some of the things that we do. That cooperation and camaraderie has already been built, and we're continuing to build on that. So with preparedness and our immunization and all of those other things listed on the slide, we were very excited. We just got a new grant for Medical Reserve Corps. I remember when I was in medical practice here in Frankfort, I was part of the Medical Reserve Corps, and that kind of petered out because there wasn't funding to have somebody really champion that, and we've got some new funding. So we're really going to work hard with our local providers to be sure that they know in case of emergency, that's not when you have a training. In case of emergency, that's when you call and say, remember those desktop trainings that we did? Well, it's time to kick that into gear because we need you. Workforce development has been extremely exciting. We are not only looking at building and bringing in, we had all of these folks that were working with us on COVID, and we've been able to kind of go to them and say, we have open positions because we've seen how you work. We know your work ethic. We know your abilities, and we want you to stay on, and we have positions for you. So not only are we trying to fill empty positions, but we're also trying to develop our workforce of the people that are already there, providing them with training opportunities. As simple as we've had several Excel spreadsheet is not my strength, but people to learn, how can you take an Excel spreadsheet and let it work for you? How can you use Word to work for you? Tools they use every day that they use maybe just on the surface, but how can you take that tool and make your job easier and more efficient? How can we give you more opportunities to get certificates at local universities, different trainings? We're working with tuition payment for some staff through a grant that we've gotten for CDC for workforce development. We're bringing in high school students, we're bringing in undergraduate students, we're bringing in graduate students, and touring them through our department so they can understand what does public health do. I usually tell people we do everything from reviewing tattoo parlors to whole genome sequencing and everything in between. Very varied group, and if you've got a strength, we probably have an area where we could use you. And we've been able to work on some internships that we've been able to actually give some stipends to students, and that's been very exciting as well. And a thank you to the legislature for the salary increases that have happened across state government. We can't thank you enough for that. Now the person that started working 12 years ago is not still making what they made 12 years ago. That has been crucial for our families, to be sure that the families of our staff are able to have what they need. And then we've been able, through the way the statutes are written, to do some changes in local health departments. Some of those staff were making $10 an hour, and they could go to fast food and make $15 an hour. We've been able to bring those folks to a much more livable wage, and that allows us to not lose that staff, because if of those of you that own a business, if you've got that churn and you're training somebody new all the time, that really depletes energies that could be used toward building your business, building your work. So that has been just incredibly helpful. We're thankful for the public health transformation funding that has happened, and I think maybe the secretary can talk a little bit more about that. The only other thing that's not on this list is enhanced relationships. I mentioned that. I know talking to our Office of Health Equity yesterday, they put out some RFAs, requests for not RFPs, RFPs. Requests from lots of different organizations for equity work, and we've got 47 new partners that we didn't have before. So the more we as public health can be a part of different agencies, community-based organizations, as well as in our cabinet and in other cabinets, that's going to spread the work and the success of public health in Kentucky.
And the only thing I'll add to that is that public health transformation funding was provided. If Representative Moser were here, that happened really early, 2020, I think. And so all during the whole time of COVID, public health continued to move and work on that public health transformation. And this is really something that's been needed to happen for the last 20 years. And I think through it all, a lot of that transformation, and the quickest way to describe it is really not looking at as clinical as many of the health departments have become, and look more at public health writ large. And then some of the other things, my favorite is what I call Moo to You, which is from the cow to the grocery shelf for milk, and all of those different things that public health does that it's really in the background, but oftentimes doesn't get highlighted.
I know you've had presentations about this, but we talk about the blue box and the green box. So you've got the core things that public health, local public health is required to do, the things that nobody else does, the preparedness and the infectious disease investigation, and inspections of restaurants and trailer parks and hotels and all of those things. And then there are two other things that we've added, and one was WIC and HANDS and harm reduction services, and looking at our harm reduction programs in our health departments. And then there's the other box, there's the green box, and those are that is the work that the local community decides, the local boards of health, the local healthcare strategists determine that in our community, these are the things that we think we need to address for that overall health of the public. So it's been a real mind-changing concept, and it's been enhanced. It's been accepted by our local health departments, and they have really made this work for the state. So lessons learned, public health and healthcare professionals who place themselves in harm's way are our heroes, and there are lots of heroes. There are the teacher heroes and the social worker heroes, and I think we again step back and look at the people that really stepped up to get us through this pandemic. We were able to remarkably genetically sequence COVID-19 within weeks. I'm old enough to remember when they first did the sequencing for the human genome. It took them like 3 years or something like that to do it. We got vaccines out in 10 months. Remarkable work on the part of a lot of people. Monoclonal antibodies and oral antiviral treatments were out very quickly. We had ways to treat it. So we had ways to detect it, we had ways to vaccinate against it, and we then had ways that we can treat it. And for that to happen within that short period of time is really pretty amazing. So once a century, we at least we hope that, you hate to wish that on the next century, but we hope it doesn't happen to us again, where we have a novel or brand new virus develop that we've not been exposed to before as a human race. We know it's expensive and it disrupted everything in our lives, but it can divide us as communities, but it also brings out our best. So thank you for everything you've done to support us, and I'm happy to answer any questions. We have.
The only other thing I'd add is this, and you alluded to it earlier, we're going to be studying this for 20, 30 years. There were good decisions made, there were bad decisions made, and we're going to probably parse that out as folks examine what was effective, what wasn't, what had impact, what didn't. I promise you we were going with the best of our knowledge, and it changed over time, even within like masks and no masks and all that kind of stuff. All of that, you just go with the best of your knowledge at the time, which is what we were trying to do. But looking back, we're going to find places that were more effective and less effective. And the thing that we need to commit to do is to learn together, and to understand that we get to learn together. And hopefully, I don't want to be, have anything to do with the next pandemic. Let me just say that, nothing at all. But hopefully leaving some lessons learned for folks, so that we can figure out how to better respond in the future.
Our other deputy commissioner, Tricia Okeson, I remember one of the first days of the pandemic, the first thing she said is, let me go get the book on H1N1. For those of you that were around for that, how do we, what structures did we have, how do we pull things together? It was at least some kind of a blueprint for us to start with. So we do learn on these pandemics and try to document that so future generations can see that. And laboratory.
Thank you.
Well, thank you for that. I think it's that blueprint that I'm looking for. Certainly this was a new disease, but we've dealt with infectious disease before. And I don't think this will be once in 100-year situation, unfortunately. And I'm hoping that we have some plan in place that we can mitigate the impact of this in the future, because we know it's there, and I guess that's what I'm looking for. So I guess I'm wondering, are folks really taking a critical analysis of this whole situation? And I guess a very pointy question I'd have for you is, what could we have done better?
One thing that when I think about, and it's kind of hard to think back because it's all kind of a blur while it was happening with very little sleep and lots of activity, we were getting every COVID test in the state of Kentucky results faxed to us on a fax machine. And then someone had to collect those and hand enter that into a database before we could even know what was going on. That took untold hours. It diverted those people's ability to actually analyze the data. So one thing that I'm very pleased with, and we still have a ways to go, is our data collection is going to be much more efficient and effective so that we're not wasting our time. And wasting time is kind of a harsh term, but it was a waste of some very competent people's times to put this stuff into a database when we could have spent all that time making better decisions, being able to hone down, using the computers and the analysis, electronic analysis we have now to be able to know where are our hot spots, where do we need to go, what do we need to do. I think the fact that we are better prepared data collection wise and analysis wise, and a lot of this is coming through the CDC is doing a lot. I mean, data modernization is the biggest new buzzword, because a lot of the databases we were using we got from the CDC, and they were woefully behind in their ability to be up to date with the latest. So all of that's changing right now.
Well, opportunity always arises out of adversity, and there's certainly some great opportunities for us in the future. We saw it with, I think, the elevation of the public's perception of public health and the role they play, with the need for broadband in our rural communities. I don't think we would advance this as quickly as we have if we had not gone through this pandemic. And the advancement of telemedicine has certainly been a good result of this. But I'm just hoping we'll take full advantage of this in the future. We need to. If not, we're going to be remiss. I think the biggest challenge for any organization is to fight complacency. You know, if we don't have another pandemic in 10, 20 years, do we forget about this? Do we put that blueprint on the book shelf like you were talking about and have to dust it off again? Yeah. So again, I'm just hoping we've got systems in place that we assure that we can mitigate future pandemics and the impact of it. So that's what I'm looking for. Another thing I'm very concerned about is the fiscal impact. Because you're right, Secretary, this is going to be around for a long time, and we have geared up to take care of this. We're going to lose federal funding. I know we're pulling back a little bit, but we still have some expenses there that are going to be here for a while. So I'm very curious of what this is going to look like for our next fiscal budget for our state, because I think it's going to be a little bit challenging.
That's a fair statement. There are three things I would say in terms of kind of what we learned, what we still need to learn, what we still need to do. One was really kind of bringing the whole cabinet into the response, particularly the behavioral health side. We did that pretty early, but making sure we got to homebound, those are things that we done, but not as from CHFS perspective as a whole cabinet, like bringing the Department for Behavioral Health in and to bring the Department for Aging and Independent Living in, and really making sure that those groups were fully into the response. The other thing is, in our emergency response, again, don't hear criticism, but we're so used to localized geographic responses. Floods, tornadoes, power outages, the whole way to conceptualize a nationwide, worldwide, in this case in the emergency response, a statewide response, I think that's a whole different concept. And the third thing that we still probably need to do is it stretched our laboratory probably as close to the breaking point as possible. You all will see a new capital request for a new laboratory, and we need it. The laboratory is over 10 years old, 15, somewhere in there.
1976.
Yeah, so when you think about medical equipment and you have something 10, 15, 20 years old, it's out of date. And so I would be remiss if I didn't put a plug in for that, because it stretched us, and we know we have a lot of work to do there.
Just all the laboratory equipment produces so much heat. There has to be good heat exchange in the building, or your equipment gets too hot and doesn't work properly, and that's a challenge right now with the laboratory we have.
I think that's what I meant by complacency. You know we've got to have this, but it's. I'm very pleased that where housing is much improved, but as budgets become tighter, do we compromise on that? So that's one of the challenges.
It sure is.
Have a question from Representative Callaway.
Thank you, Chairman. You mentioned there were some federal grants that were extended through summer of 2024. So I was just curious what those were. I think there were 3 or so, briefly, what they are, the reasoning for the extension, and kind of expectations there. Thank you.
One was health equity is one of the areas. Oops. I want to look to make sure I don't say this wrong. Health equity, the laboratory, and disaster preparedness. So it was to continue to be sure that our disaster preparedness plans are all in place and those organizations are ready. The laboratory, as the Secretary mentioned, to be sure that we've got all of our laboratory testing as streamlined as possible. And I was going to add, I'm going at 2 o'clock this afternoon to the Cabinet Health Equity meeting. That's a group that pulled together, and I looked at the agenda last night, and just to see who comes to that. So it's the Department of Aging and Independent Living, and it's the Office of the Inspector General, and it's Public Health, and it's Behavioral Health, and it's the Secretary's Office. We got together to say, okay, not only are we attacking COVID, but how are we going to attack COVID in places that's hard to get to? How do the homeless vaccinations where we actually went into people's homes, and how do you organize that with the health department and with the National Guard and with all the other different folks? We reached out in areas that would not have normally happened. So that health equity work group, which is and the Secretary is on that group, is really making some inroads is how we look at all Kentuckians, because we can't have just one plan. Because we don't have just one type of Kentuckian, we have so many different types. So that work is continuing to move on, and we're very excited about that.
And again, to emphasize the laboratory piece, because we know we had real challenges with getting enough capacity there. The same with the disaster piece. We had a lot to learn on a statewide. That's kind of what I was alluding to. We had the whole conceptualization of a statewide response is very, very different. And then, as always, when you look at different Kentucky counties, and you can see which ones have where poverty and healthcare reside together in terms of negative outcomes. Again, if you look at some places in eastern Kentucky and some of our more challenging counties, how do we make sure that we direct resources where they are needed? And that's really what we talk about. That as we look at poorer health outcomes, often related to poverty, how do we make sure that we're being supportive of those communities all across Kentucky, from a geographic perspective, from every perspective we can, from populations that we know are vulnerable.
I have 2 other committee members in my comment question queue here. We'll allow them to present their comments, questions, and then we're going to move on our agenda. Senator Chambers Armstrong.
Thank you, Mr. Chair, and thank you all for being here. I just had a question about continued access to vaccines and healthcare with the ending of the emergency declaration. And I was curious if the reduction in federal funding is anticipated to create any barriers to accessing vaccines, particularly in the situations you were just talking about, those high poverty, more rural areas as we transition more to a private market. And relatedly, I was curious about plans, budget, communications to remind Kentuckians to get their ongoing COVID booster every year. Are there plans for that?
So moving to the commercial market, there are vaccine programs within the public health departments and the federally qualified health centers. Will there be bigger access issues as we move to a commercial system? Of course, yes. Couple that with what you'll hear in a little bit about Medicaid unwind. The answer is yes. And we know that, and we'll have to direct resources that way. You may see us with how we structure what our requests will be for you all in the next session. The other, in terms of public outreach, there are some funds available for that, but that, as Chairman Meredith pointed out, those funds will dwindle as time goes on, and certainly the COVID booster is important. I'm looking forward to getting my next one, and so is flu, and some of our vaccine rates have gone down, so we have a lot of work to do on all vaccines, children's vaccines, just basically all, because we've seen those rates go down over the past couple of years, and so there's a lot of work to do there.
Thank you. Thank you, Mr. Chair.
And we another group that formed during the pandemic, and I hate to start mentioning organizations because I know I'll leave them out, but we sent out a lot of communications that were from KHSAA, Department of Education, American Kentucky Medical Association, from DPH, from it was so many different logos at the bottom you could barely read them, which is a good problem. But those people have been meeting regularly, and they have some funding for that kind of stuff too. So what I say about public health is we know how to pull people together, and we don't have much money to do something. But if we could put our dime in the table and they all put their dime in, then we've got $1 and we can really do some outreach. So I'm anticipating that those collaborations will continue, not just for COVID, but for RSV and for flu and for those childhood immunizations that have really gone down in Kentucky, which is alarming.
Thank you for that question. The last question for this session is Senator Douglas.
Thank you, Mr. Chairman. I want to thank both of you all for being here and providing the information that you're providing. Hopefully we can answer this question pretty quickly. Has there been much work in the area of how the initial outreach to the healthcare providers can be improved in terms of a standard platform of how we can get information to you, what information we need to provide, those types of things, because there certainly is a difference between our private practice healthcare providers and our tertiary care providers. And we all, a lot of people don't know, but within this space, we know that there were some things that we could have done a little bit better. Has there been anyone looking at streamlining getting this information out? And thank you very much.
Yes, I think again, part of that lessons learned, where we didn't have good communication, where we could improve. We've looked in both our health information exchange side, this is a different system, but our CASPER side, our immunization side, all of those pieces, we know we have improvements to make. And so get that back and forth communication. I was with my primary care physician about 2 years ago, and he was saying to me, I need to know the genome of this. I've heard it from my primary care, so I know that we have improvements to make.
And we had great relationship with the Kentucky Board of Medical Licensure and the Kentucky Medical Association. KBML is very careful about sending out mass emails because everybody wants you to send information out to every physician about every project they have, but they were very helpful in working with us to be sure that the pertinent, most important things were getting out to the providers in the state and the Board of Nursing as well.
Thank you, Mr. Chair.
I know there may be some other questions, comments, but we're running really late behind. I assume Dr. White, Secretary Freeland, you folks will be available
Absolutely.
to take questions afterwards. I
Absolutely.
appreciate that. Appreciate your presentation. Next on our agenda is we're going to hear from the Department of Medicaid Services.
Oh, stop sharing. I didn't have an X. Oh, there it is. I couldn't find the X to click out. Let me get it.
Good morning.
Good morning.
Glad to have you with us. If you would, you know the routine. Please identify yourself for the record and feel free to proceed.
Thank you so much. My name is Veronica Judy-Cecil. I am the Senior Deputy Commissioner for the Kentucky Department for Medicaid Services. And you already know Secretary Friedlander. So we'll just dive right in. Wanted just to give a little bit of context to what's going on from March 2020 to now June 2023. This is a snapshot of our enrollment during that period of time. Honestly, going forward, we're probably going to do away with looking behind and instead looking forward to see what the trend's going to be going out. But this is always a really good sort of way to ground us in exactly what happened over the period of time. So in March of 2020, we had about 1.3 million people. In in April of 2023, which is when we started unwinding, we had 1.7 million. So quite a growth. What we try to dig into is how much of that is from continuous enrollment, how much of that is natural trend, but it doesn't really matter. We just had an enormous growth over the period of time. So just kind of wanted to alert you to that. Next slide. This is our case distribution list, and what that means is, so we have 12 months to perform renewals for anyone that was part of the mandatory continuous enrollment coverage during the public health emergency. So state Medicaid agencies had to continue to cover individuals regardless of their change in circumstance during the public health emergency, which is why you see we have a growth in our enrollment over the years. So now for our planning on how we're going to do that, because that's an enormous increase in what our normal renewal over 12 months. We are, prior to public health emergency, we were required to do an annual redetermination of somebody's eligibility. So now we're going and doing that larger number. So we had to come up with a plan, and this is just a snapshot of what cases, and by cases I mean it's at the household level. So sometimes we're talking about households because in Kentucky and in most states you do your eligibility determination based on the head of household. Generally, if the head of household is eligible because of income, the entire household. A household can be one person. It could also be 2, 3, 4, 5. It just depends on how many people are actually part of the case. So when you're looking at caseload and individual numbers, you're going to see a little bit of a difference there. What I wanted to point out on this slide is this is different for those of you who might have seen a previous caseload distribution slide. This has changed a little bit, and the reason for that is because we are implementing 12 months continuous coverage for children as part of our unwinding. This is mandated by federal law for state Medicaid agencies to implement this January of 2024, but Kentucky decided to go ahead and do it for our unwinding period so that children that might be redetermined prior to January 2024 have access to that same continuous coverage for a child that might get determined after January 2024. So we just really wanted to treat the children the same throughout the unwinding period. To do that and to implement that in our system, because it was a decision we made in April, we had to push a lot of our cases with children on it to later in the unwinding period. So you'll see July and August lower numbers than what we previously reported, and that's because we've moved those cases to later, primarily through that January through April time period. The other thing...
The reason Medicaid numbers changes is because they're so big and they always change. I always like to say when I leave the 5th floor in the Cabinet for Health and Family Services, and by the time I get to the 1st floor, the numbers always change a little bit. And you can see these are estimates. All of these numbers as we go through the year are going to change. That I can promise you. But you get the general flow of what our review is going to be. I do also want to back up one. This is something that's going on nationwide. So for 3 years, nobody did any redeterminations in Medicaid. You couldn't do that. You couldn't take people off the rolls unless they passed or moved out of state, or you would risk losing what was called the enhanced federal match rate for Medicaid. That's billions of dollars. So there really aren't any states. There aren't any states that violated that provision just because it was just too big, and we didn't either. So now we're unwinding. Now we're doing the recertification. We have experience with this in our SNAP program, where we started doing recertifications really about a year and a half ago. In that program, that's a food stamp program, formerly known as food stamp, that's SNAP. And we saw at the time it swamped our DCBS workers. That's you double their workload. This is probably a 20 to 30% increase in their workload just to do this piece of unwind. So, we've had to beef up our call lines. We've given our connectors a little more access within our system. We're using private insurance agents. We're trying to do everything to not get a huge backup. It's still, if you call our phone lines, you're gonna have a little bit of a wait. That's just true. And so we try to do a lot of things to make it better, and we continue to work on that. But just to know that this is a huge increase on the staff of DCBS. We've done some hiring, we've done a lot of different things, but just know you'll probably hear some constituent concerns about, I called the DCBS phone line and I was on hold for 40 minutes. Yeah, it probably were. I wish I could say we were doing better than that, like our commercial partners, but it's a challenge. And this addition of folks calling in and talking to us, it is where we are, and I just want to be really clear about that.
I think the other thing to note from that is that we are learning lessons every day. We have completed May renewals. We're in the process of June, and so we've learned some lessons from that, so that as we move forward, we can maybe address those, including bringing on additional staff. Because you saw towards the end of the distribution plan, it is a larger number, and we want to be prepared for that, certainly. So here is a snapshot. This is of June 2nd, and as the Secretary mentioned, really it changes every minute, and the reason for that is because our sister agency, the Department for Community-Based Services, who performs our eligibility determinations and redeterminations, are doing cases every day. So it really can change in a moment. But here is a snapshot of June 2nd. This may look familiar to some of those who are on the Health and Human Services Delivery Task Force, because you might have seen these numbers. But the individual count, and again, we were talking cases in the last slide, but this is the individual count, which is the number we have to report to CMS. The individual count of those who went through a May renewal is 74,004. Of those, we were able to approve 37,182. And unfortunately, we did terminate 34,124. You see there it says passively renewed and actively renewed. The difference between those, a passive renewal is our system can go out and do an automatic verification of their eligibility. We have a federal hub and other databases available to us to be able to verify somebody's income, citizenship, a whole bunch of different databases. If we're able to go and verify with those databases, the member actually has to take no action because we've been able to determine them eligible. And that means they'll just get that notice of eligibility, nothing further for them to do. Sometimes when we do that, even if it is a passive renewal, we can't verify everything, and they'll drop to what's called a request for information. So we'll send them a pre-populated form that tells them exactly what it is that we need from them. Either the income information came back saying different than what the person reported, a whole host of reasons. So they'll get that request for information. That means they have to take action. Even though they were identified as a passive application, they have to take action before the end of May for the May renewals. The actively renewed are individuals where their Medicaid eligibility has some other components that are necessary, like resources and assets, information that we can't go out and automatically ping on the databases available to us. So they get what's called a renewal packet. That packet's a couple of pages long. It requires just some additional information. It really, again, is pre-populated and just asks for the gap of information that's necessary for us to make that redetermination. So that's the difference between passive and active.
Some new information. We ran the folks who lost eligibility against what's called a third-party liability list, meaning checking to see if they have other insurance. About 27% of these folks have now some other health care coverage. So we're asking that to kind of understand that, who's moved from Medicaid to private insurance with it, or Medicare. And so that number, I think it's good news, is about 27%. And then that reinstated piece, I think we're up over 3,000 now. So it's basically folks who go to their pharmacist, find out they don't have insurance, realize their Medicaid lapsed, call DCBS, get reinstated. That's what that number is. We've got about 3,000, a little over that number as of last week.
As of Friday.
Friday.
Yep.
So that number is going to be constantly changing, that reinstated within 90 days. And think about that. That's right. You go to your pharmacist, you have a doctor's appointment, and all of a sudden they say, well, you don't have Medicaid. You're no longer enrolled in whomever, right? Molina or WellCare or whomever, Aetna. And then folks go back in and they renew their coverage. It happens in all of our eligibility programs. You go to a month, you've ignored the phone calls, the texts, the emails, the letters, and then you realize, oh, I don't have this coverage anymore, and you come back and get it. We see that in, like I say, every eligibility program that we have, every one.
Yeah, I think the only difference for the reinstated during the unwinding is that if they come back in within that 90 days, they do get reinstated back to their termination date. And that's not necessarily the policy in normal eligibility and enrollment processes. So the great news about that is they do get that retro coverage for no gap in their care or payment for services delivered during that time.
And in the interest of speed, this just gives you an idea of kind of the outreach that we've done. One of the managed care organizations said that a couple of folks that they called said, why do you keep calling me? So we really have tried to do a lot of different things with outreach, and just to know sort of some of how we've done that, and that's what this slide is about. And then this just gives you some of the renewals, and again, what it looks like for the month coming up. It's going to take us probably a quarter, maybe 4 months, 5 months to really get a handle on what this is going to look like in terms of folks that come back in, folks that lose coverage, trying to understand who continues to have health care coverage in a different way. So this impacts budget because it'll impact the number of eligibles. So there'll be a lot of things that we are juggling heading into the next legislative session, particularly relative to the Medicaid budget. And there are just a lot of balls in the air. And one of the biggest things that relates to Medicaid's budget is how many eligibles are there. Mm-hmm. And so we had predicted, I think, kind of internally, a couple of 100,000, but it looks like it may be higher than that. But then if you look 1 month to the next in terms of what the total number enrolled in Medicaid, it may be more closer to our projections. It's just, there's a lot in the air right now. This is our first month. Bear with us. We report this every month. Happy to do it. There's a website. It's the Kaiser Family Foundation that has kind of a running total on this, and all the states report. We're about middle of the pack in terms of folks losing coverage is what it looks like to me. So you can look at that site. We will report to you and let you know the challenges that we see moving forward. But there are a lot of them. We're learning with every other state, but some states have had hundreds of thousands of folks who have been disenrolled. And like I say, we're about the middle on that. So just to let you all know, and we'll see how we go. Other states took different approaches. We really tried to put those folks we thought might be ineligible in our first couple of months, but we won't know until we actually get through this. So again, just this is what it is. You see a lot of terminations for not returning information. That is also the experience across the country. and we'll continue to work on that. Again, just sort of letting you know what our outreaches have been there. I'm trying to, in interest of time, Chairman Meredith, move through some of this, and then let you know we've had some enrollment pick up a little bit in our qualified health plans. That's the state benefits, but not very many, right? It's kind of hundreds, not thousands. We were hoping for a bigger uptake, but we haven't seen it. But we'll report on this too, just like the third-party liability piece. Just like the re-enrollments, we will let you know as we know. And as I said, there's some the best national report I've seen is that Kaiser Family Foundation so far.
Well, and just as folks roll off of Medicaid because they're ineligible, if they are eligible for a qualified health plan, we have specific approaches around those individuals to help connect them to choosing a plan so that there's no gap in their coverage or as little gap as possible. So not only is the state doing that, the Medicaid managed care organizations are very proactively making sure that individuals understand they can choose that option if they don't have any other coverage options available to them. So this is a slide that just reflects, we put a lot of things in place for the public health emergency. And so now a lot of those flexibilities have ended. We were able to extend some, and some we put permanently in place, like the telehealth. We discovered that there were lots of policy changes we could make around telehealth, and working together with the legislature and legislation that was passed, we did put those permanently into place in our regulation and in our state plan. So there are some things extended. We're continuing to watch that. I think the critical piece we want to make sure a lot of providers know is that during the public health emergency, they were allowed to use platforms that were non-HIPAA compliant, so like FaceTime. And the Office of Civil Rights is going to go back to enforcing HIPAA compliant platforms in August. So providers who have been using that as a way to do telehealth, they just need to make sure they're using a compliant platform for that.
And telehealth, again, it is one that's really important. For years, we've talked about healthcare in rural areas, and what can we do. And transportation is always the biggest issue, I think, across the state. Mm-hmm. So hopefully, telehealth has been available in many ways for years, and we just got pushed to adopting a more robust telehealth reimbursement structure. More robust. Providers got used to it. Everybody got used to it. So we probably jumped ahead 20 years in telehealth, and it really does address a lot of issues around health and rural health appointments, a lot of the transportation challenges that folks face. So we'll continue to explore how that can work. Broadband, again, is critically important for the dissemination of strong telehealth. So all of these things, as you all know, are interrelated, but it's an important piece that I think is definitely worth talking about. Quickly, again, there's a phase down of the FMAP. Again, I think that's probably going to provide us some relief as we look into the next 2 years for the Medicaid budget, because none of us budgeted this. Wasn't budgeted in the General Assembly's budget, wasn't budgeted in Medicaid. So there will be some funds going into the next biennium that should be helpful, again, with all the balls in the air around eligibility and unwind and some of the other changes. But just know that this gives you the schedule and what that looks like as we go forward. And then
our website has a lot of resources on it. We are keeping a weekly update of the numbers around unwinding. We have resources on there for providers, for advocates, stakeholders, anyone who may be helping support Medicaid members through their renewal. We really have tried a very broad approach to just working with organizations across the state. Our providers have been extremely helpful and have a desire to help members going through that and make sure they understand it. We took some actions like putting the redetermination date on Kentucky Health Net, which is the system that providers go in and verify eligibility so that they can, when the member comes in, that they can, have them check that. And again, lots of flyers for providers to hand out or for advocates to use in communicating with Medicaid members across the state.
But Senator Chambers Armstrong, you haven't seen the same kind of broad public communications like where you hear us on radio stations or see advertisements, and that was a conscious decision. And the reason it was a conscious decision is I got worried, and I'll own it, that if we did that, then everybody tried to call our lines all at once and they'd collapse. Kind of like the earlier COVID discussion, we'll see if that's the right decision or not as time goes on. We're not at the worst end of the states, so maybe it wasn't a horrible decision. But it is a we'll see. That is absolutely true. We've tried to be really targeted about how we communicate this, both the members and providers, because that's really, it's that relationship that's going to make the difference. I think the broader campaign in this case isn't going to have the same impact. We've let all our community providers know. We've let individual providers know. Our managed care organizations are doing outreach, and again, we'll see. I hope it's the right approach, but I got worried about I really did get worried about too broad an approach, because it just that's probably what's that phrase? I was worried that would generate more heat than light. So. Thank you.
Let me put some historical perspective on this. 2017, we had, I think, 1.4 million Medicaid recipients. Medicaid budget was $10 billion. Roll it forward to this year, we're 1.7 million, $15 billion budget. A lot of tremendous economic push and pull on this that I'm not sure we've factored in. We haven't talked about the impact of inflation at all on this program. So I think the next fiscal ask for the budget is going to be a little bit alarming. And I've always been in a position that we can control this if we've improved the health of our population and reduced the number of Medicaid beneficiaries, not forcing people off. I don't think there's a person in our legislature in favor of that, but getting people back to gainful employment when they get commercial insurance should mitigate this some. But even with the economic expansion that we're seeing right now, I'm not seeing this numbers being mitigated at all. Do we have a disconnect there? And are we giving some thought to, we're adding more Medicaid recipients with a healthcare delivery system that's kind of fragile to begin with in terms of being able to provide services. And when you're only getting 75 to 80% of your costs to begin with, seeing more patients doesn't exactly make a good business model for financial viability for healthcare providers. So there's a lot of, he said, push and pull on this, but how do you see the program truly in the long run? Are we consciously focusing on trying to reduce the number of Medicaid beneficiaries? And are we really making a concerted effort to improve the health of our population? Because we've got to admit, we're not moving that needle at all. We have not been successful at that.
Absolutely, and certainly not quickly enough. And I think two things. One, the reason we ran the third-party liability piece was to see who had actually converted. So 27%, we probably want more. But again, just to let you know that there is some movement there. Probably not enough. I'll agree with you on that, absolutely. But we'll keep an eye on that, and we will keep reporting to you all on that, because I think it's an important number. And so we'll see where that goes over time. As you know, with some specific providers, particularly hospitals, we've been able to make some changes with the partners in the General Assembly around what's called our HRIP program, and I hate to use initials here, but it basically it reimburses hospitals at the average commercial rate. But the hospitals pay the difference, and so we're not actually taking any of the taxpayers' money from the general fund to fund that piece. I think it's a good model. I've talked to a lot of different providers to try to get that done. It's hard, it's complicated, and so we're still in some of those discussions. We have the nursing facility folks here. We provided the $29 increase. We tried to do as much as we could on an inflationary increase. I'm sure it's not enough, right? So it's how we do that. When we talk about rates, then oftentimes it's more general fund and expands Medicaid rather than contracts. And so it, you know this, but it is a complicated thought process. That's not the word I'm looking for. Algorithm, system. There, that's the right word.
How about a Gordian knot?
Yeah, well, I would take that too. But again, it's hopefully what we do together.
Representative Burke, you have a question, comment? Berg. Sorry, my apologies, Senator Berg.
Thank you. This is a very interesting presentation, and I really apologize for being late this morning. If I am understanding you correctly, we're looking at approximately 300,000 Kentuckians that are going to be, we anticipate are going to be losing their Medicaid coverage. Is that correct?
If we followed our current trajectory of the first month without any of the re-enrollments, right, without any of that, yeah, you're looking at around that number. I don't believe that number is going to hold. We're already seeing re-enrollment. We're seeing some that 27% that actually went to third party.
Yeah.
So I don't think it's going to be that number in terms of folks who lose coverage altogether. And I think we're going to have to wait and see through the next several months what that number looks like of folks who then re-enroll, or if we're able to do a better job when word gets out that, yeah, when they say you're going to lose your coverage, you're going to lose your coverage. And if that gets in the community of Medicaid recipients, if those numbers will change. So I hate to say it this way, but it is absolutely true. We'll see. And we don't know. I would not be surprised as we thought about it and looked at it and what the possibilities are. I think a couple of 100,000 is not out of the question. And I still feel like that might be a solid number. But in my head, that also didn't include those folks who converted to third party. So
Perhaps minus 25%.
Yeah, maybe, but we'll have to see if that number holds. And I don't know if that number is going to hold. I don't know if the disenrollment number is going to hold. There are just so many things we don't know at a first month glance.
The difficulty too is the case mix is different across the 12 months. So we didn't just take all Medicaid individuals and distribute them evenly. We have prioritized populations differently within the unwinding period. So it is hard to take 1 month and extrapolate it because of that reason. They're just, the reason their eligibility might change, for instance, if they're 65 and older and now eligible for Medicare, they're in the first 6 months of the unwinding period. So that it's really hard to project for that reason. And the other difficulty is when somebody does come up for a redetermination, their circumstances could have changed from when we did our snapshot. As the Secretary mentioned, we tried to estimate, but by the time their redetermination date comes up, their circumstances could have changed since then.
Well, to that end, we will revisit this again
Oh,
as
yeah.
we look at the Medicaid budget later on in the year. So I appreciate that. And Senator Funky Fromeyer, you have a question, comment?
Thank you for the opportunity to look at this a little deeper. When I looked at slide 3 and it indicated almost a 50% increase from 58,000 to December 31st, 2023 to 83,000, 50% increase, it makes me ask the question, how then would we encourage people to earn at a level so that the taxpayers aren't covering their insurance, so that they're covering their insurance? And is there something that we legislators can do to promote that gradual move off of Medicaid, perhaps over, you now know you've achieved income at this level, and we want to help you bridge it, but our objective is to get off of the taxpayer-funded Medicaid and get on your own funded care of insurance.
Two things. You see some of that up and down in these numbers. These are really our projections of the folks we're going to bring in to actually check their eligibility. So when you look at these numbers, some of these are, it's actually kind of a very simple explanation in terms of why these numbers fluctuate. You know, some of this has that first downturn, like in July and August. Think about that also as our workforce. Some of our folks go on vacation, some of the folks go on vacation, so we kind of brought that number down, particularly after the first 2 months, so we could work on that. When you think of November and December, there are a whole lot of vacations in there, and to try to do a high volume during that time period, probably not a great idea for us to even try. So that's why you see that variation. But to your point, the how do we encourage folks, right, to get privately insured? And I think that's as much an economic development question and getting folks to living wage jobs and supporting folks being able to do that as a Medicaid question. So I think, as with all these systems, it's going to take all of us, not only working on the health care side, because I think the health care is important to people who have chronic conditions and things like that we can support them to be well enough to work. But then there have to be the jobs for them that have health care coverage. So it's not only a Medicaid issue in my mind, it's also an economic development issue.
We did implement House Bill 7, so every Medicaid member has the opportunity to do job training, and we connect them to the labor and education and labor cabinet, so they get a report of Medicaid members who have asked to be connected to those opportunities for job training.
Thank you.
Mm-hmm.
Last two questions. Senator Douglas is next on the queue, and then Senator Berg has a follow-up question. So we'll end the discussion with that. So, Senator Douglas.
Thank you, Mr. Chairman. Secretary, perhaps you could help me. I may be misunderstanding the program. Was the Medicaid program, or maybe you could clarify this for me, meant to be a temporary assistance net?
That's a good question.
Was it meant to be, not where we are today, but was that the initial intention?
I'm not sure. I'm happy to look back. That goes back to LBJ, I think.
Yes, sir, it does. I'll let you look it up. I know the answer, but we'll wait.
Yeah, and there are folks, actually a lot of folks in Medicaid who have disabilities,
Yes.
who may, like the folks on the waiver program, the folks who are, it's called, there's a whole set of eligible folks who are called, who are, it's a category, so I apologize for how this sounds, but this was done in the 60s. Age, blind, and disabled, it's called ABD. And those folks who probably are not going to get employment easily and may not have options, that category in particular of Medicaid eligible recipient, I don't know how temporary that is.
Okay. Well, again, I know the answer,
Yeah.
and I'll wait. I'll wait for your answer. And you're exactly right in what you're describing. However, that's a very, very small portion of the Medicaid. And I rail against trying to use a small percentage to justify the great percentage. I just wanted to bring that out. May I ask one last question?
If it's brief, sir.
We often speak of those who lose coverage under Medicaid. Why do we never really speak of those who have been encouraged to move on because of the improving the economy? We don't seem to have those kinds of statistics.
Well, that's the 27%. That's what you ask is absolutely right, which is why I'm going to try to give you all, and why we're going to run for those folks who, that 34,000, that's why we ran the third-party liability, so you can know that 27% of those, right, are actually getting some kind of third-party insurance. And we're going to keep track of that. I think it's an important number as policymakers for you all to know, and an important number for us to track.
Thank you very much. I appreciate that. Thank you, Mr. Chair.
New committee rule, no more rhetorical questions. Senator Burke, before you ask your question, let me just give the committee a brief agenda update here. We're not going to hear number 5, budget bill request 80. We're not going to do that this session. When we're getting late in the hour, I want to make sure that we cover the refer to administrative regulations, just if you have any questions, and then we'll end with our presentations from the folks from Kentucky Association of Healthcare Facilities, Kentucky Nursing Association, and KMA. So just wanted to make you aware of that. So Senator Burke, if you would, ask your question. We'll proceed.
Thank you, sir. I did have a follow-up. Now, actually, I have two. Just in response, I mean, people have to understand that at this point, private insurance is coming literally with $14,000, $20,000 annual deductibles. That means that a family has to come up with that much money out of pocket to use their insurance every year. So when we're talking about moving people from Medicaid to private insurance, you have to understand the jump that we're asking people to make. Think about your own economics, your family economics. How many of us in this room could afford a $20,000 annual deductible? It's not doable. And that is one of the problems when we're looking on what do we do? How do we balance this? How do we maintain a healthcare system but still maintain access to that healthcare system? It is a much more complicated question than just expecting people to get a job. Most of these people already have jobs. It is, to put it to that level is really doing a disservice to what the actual issue that we have to face is. And this is my opinion. My question, as we're moving large groups throughout the country off of Medicaid and into either private insurance or no insurance, is this a point for us to collect good quality data as to whether or not having people on Medicaid in the long term is a better financial solution for the state than not having them insured at all? I mean, you would think this may be an opportunity. Now, I know there's confusions because we're coming out of a pandemic. That's going to obviously, but it seems to me like we should take advantage of this point to try to figure out what is it going to do.
Senator, with all due respect, I think you're asking a philosophical question here, and I think it's beyond the purview of this presentation. I think it's warrant further discussion, but I don't think that's a fair question to present at this point in time, particularly with the limited amount of time we have. I think all of us agree with your points, but I would ask that we could, let's move on and have this discussion at a different time, or maybe off.
Absolutely, but I would like to say, and it probably is worthy of a presentation at a future meeting, we work with our university partners. There's something called a state university partnership, and we talk to them about what it is that we might like to see their graduate studies look at, right? And so there's room for that kind of discussion on what we might ask them to look at. But that's a whole big different discussion.
What's our Gordian knot we're talking about?
Yes,
we can talk about moving people off Medicaid,
Yeah.
or we can talk about reducing the cost of health care
Right.
through better outcomes and less bureaucracy. There's a lot of different moving parts of this, and
Yes, sir.
which one we want to go down today is not discussion today. But appreciate your all's presentation.
Absolutely.
Appreciate the information.
Thank you.
Certainly, you'll be available. Anybody has some
Absolutely.
questions afterwards. Our last presentation, as I mentioned, is with the Kentucky Association of Healthcare Facilities, Kentucky Nurse Association, Kentucky Medical Association. I'd ask those folks to come forward, but as they're coming forward, I'll ask our committee to take a look at the consideration referred administrative regulations, which you had. There are several that are there. Are there any questions or concerns or comments about any of those regulations? Seeing none, then we will move on. And what we're going to ask, once these folks make their presentation, we've provided about 10 minutes for each one of those. Let's hold the questions to the very end if we could. So please introduce yourself for the record and proceed.
Hello, my name is Betsy Johnson. I'm the president of the Kentucky Association of Healthcare Facilities. Thank you, Chair Meredith and members of the committee for having us today. We appreciate the opportunity to be here with our colleagues in ARMS, the Kentucky Nurses Association and the Kentucky Medical Association, to discuss the challenges that Kentucky healthcare providers are facing after COVID-19. Our long-term care members would tell you that COVID really isn't over because the pandemic has had such lasting impact on our operations. This committee has seen this slide before. I wish I could tell you that things have gotten better, but unfortunately they have not. We are still down close to 4,000 workers since February of 2020. I hope it isn't lost on anyone, I don't think it is, that we cannot take care of our elders without the people in our facilities. Facilities are reducing their census, facilities are closing wings, our member facilities are trying to manage during this time of workforce shortage crisis. It is simply having an impact on the healthcare continuum in Kentucky. And what it simply means is that people are not getting served. And on top of that, meanwhile, in Washington, D.C., we are facing a federal staffing mandate. I did receive an email from our National Association CEO this morning, Mark Parkinson. He informed us the Biden administration said this new rule, and I hope you can still hear me, the new rule was supposed to come out today, because as Chair Meredith said, we're at the first day of summer. They said it will be issued at the end of spring. We do not expect that rule to come out today, and in fact, thankfully, our National Association believes their lobbying efforts are working to explain to both the Centers for Medicare and Medicaid Services and the Biden administration that there simply aren't the people to comply with this staffing mandate. So stay tuned. We do believe a rule will be issued, but we're hoping that they will listen to the skilled nursing facilities across this country that are struggling to find that workforce. And I want to thank, unfortunately, money is important, and I think Secretary Friedlander mentioned this as well. I cannot thank this body, Chair Meredith, Chair Moser, members of this committee, House and Senate leadership, for listening to us during the COVID-19 pandemic and implementing the $29 Medicaid rate add-on effective retroactively back to January of 2020. That is still in place and is supported by both the legislature and Governor Beshear. And we want to thank Governor Beshear for announcing a couple weeks ago that we will be receiving a what's called an inflationary adjustment. We receive inflationary adjustments every July 1, but this time the Department for Medicaid Services really looked at it and realized that the inflationary formulas were not sufficient based on real true cost of what skilled nursing facilities are experiencing. And they were able to adjust it higher, which means that based on statewide averages, we anticipate the rural increase will reflect an overall adjustment of 8%, and the urban adjustment will be 7.9%. And we had approached the Department for Medicaid Services back in September about rebasing our rate effective July 1 of 2024. So you'll be hearing from us during the budget session in 2024. They have agreed to do that. But meanwhile, then my members were calling me and like, Betsy, that's great if you can get rebasing of our Medicaid rate, which by the way has not been rebased since 2008. And I know it's a complicated formula, but they look at the cost reports. So they haven't looked at the cost reports since 2008. That's a long time ago. I was at Medicaid in 2008. So that was a very long time ago. So what they're going to do is look at the 2022 cost reports, which will reflect what it really does cost to operate a skilled nursing facility, and then rebase the rate July 1 of 2024. But meanwhile, my members were telling me we can't really wait another year. So that's when we started having these discussions with the Department for Medicaid Services. And that's why they agreed to look at the inflationary rate and were able to give us a significant increase starting July 1 of 2023. And I know we're out of time, so I try to make that quick, but I'm happy to answer any questions that you might have at the end of other presentations.
Thank you. We'll ask the committee members to hold those and continue with our presentation. Mr. Padgett, you want to go next?
Thank you, Chairman Meredith, members of the committee for having us here this morning. My name is Patrick Padgett. I'm the Executive Vice President of the Kentucky Medical Association, and we represent the physicians of the state, throughout the state, in all geographic areas and all specialties. I appreciate the opportunity to come in and speak this morning about the state of the physician community as we come out of COVID. And I have some things to say, but I think the number one statistic that I can show you about the state of physicians in Kentucky is simply that between 2019 and 2022, according to the Kentucky Office of Rural Health, we lost 590 physicians out of the state at a time that we needed more physicians in the state. So that's a big loss. And physicians not only treat patients and try to maintain their health and make them healthier, and make them more productive, but they are an economic driver in the state. According to a recent study by the American Medical Association, on average, physicians bring about $1.9 million apiece of economic activity to a region. So when we lost 590 physicians, Kentucky lost over $1 billion in economic impact. So what would it take to improve the situation? We actually did a member survey. It's the first member survey we've done in nearly 10 years to talk about a number of issues with our members and ask them how they felt. And we used a national group, like so many others do, that work with other associations and other groups to help us with the survey and actually conduct the survey. We did that last fall, and we surveyed all of our members. And I think they had some very interesting things to say about what was going on in the practice of medicine at that time. Before I talk about that, I'll just say that according to our survey and the responses that we got back, around 63% of physicians right now consider themselves to be employed and not in private practice as a business owner. That's a big change from what medicine used to be. Just 10 years ago when we did that survey, it was just the opposite. It was about 40% who were employed and 60% who were in private practice. So that's been a big change in medicine in that time. We also asked, however, various questions about what's going on in their practices and the physician well-being and the state of physicians in Kentucky. And right now, according to physicians, about 44% are experiencing more stress now than before the pandemic, but it's manageable and doesn't impact their quality of life or their professional life, which is good, and I think we've all experienced a lot of stress through the pandemic. However, 23% say that they're experiencing more stress and having a difficult time managing that stress, and it is impacting their professional satisfaction in their work. That's nearly a quarter of physicians in the state. So if we have 10,000 physicians, that's around 2,300 to 2,500 physicians who are experiencing stress that's impacting them. We took that number and we wanted to do something about it, and we actually started a program where we provide free and very private counseling to physicians who say that they need it. We worked with our local medical societies to set up these programs, and we appreciate the passage of Senate Bill 12 during the last session, sponsored by Dr. Douglas, that helped protect those programs for physicians, and we hope to expand on those programs in the future. But we also wanted to get at what's causing the stress in physicians and what's really impacting their practices. And according to our survey, the number one stressor was administrative burdens that are being imposed on physicians, and the number one administrative burden that they focused on in our survey was prior authorizations. According to our survey, 81% of physicians said that prior authorization delays access to necessary care for their patients, sometimes, often, or always. And of those, 61% said that the main prior authorization problem was trying to get and obtain prior authorizations for medications that physicians believe their patients need. 47% said imaging and 30% said procedures. We also got back just some anecdotal comments from physicians, one of which is on the screen, where unfortunately this physician said that he had a patient who died while waiting on a prior authorization. Now, administrative work is something that we all have to deal with no matter our profession, but what's different, I think, for physicians is the need to constantly reiterate, explain, cajole, and follow up with those who have not seen or treated the patient so that the patient can obtain the care that the physician knows that he or she needs. This ongoing burden also keeps physicians of all specialties from treating more patients and places an administrative barrier between the physician and the patient. I think you heard Dr. White earlier talk about they're trying to develop procedures to save time within the cabinet if there's another public health emergency, and physicians are always looking to try to save time so that they can treat more patients. And unfortunately, that administrative burden is just becoming overwhelming for physicians. Of course, the impact on physicians mirrors the impact on patients. Stress, disruptions in their personal and professional lives, and the overwhelming frustrations they experience when they must, for whatever reason, for whatever change has been made, they might be on a drug for a long time, and then suddenly they have to go through this prior authorization process again because there's been some change within the health insurer that they have, and then the physician has to go back through and explain that this patient has been on this medication for a long time, it works, switching them off the medication could have an impact on them. I think the frustrations that physicians have, and an example of what they deal with, was recently highlighted in an article, as a national article that actually precipitated a congressional hearing around one insurer who, it wasn't with prior authorizations, I would call it post-authorizations. The care had already been provided, and then the claims submitted for payment, and this insurer would take those claims and batch them into batches of claims, and then they would just be denied by a computer, essentially, that would pick them out and deny these claims. Thousands and thousands of the claims. And as one person said in the article that worked for the insurer, put yourself in the insurer's shoes. Why not just deny them all and see which ones come back on appeal? From a cost perspective, it makes sense. I can tell you from a patient perspective and from a physician perspective, that doesn't make sense, because the physician is the one actually sitting there or standing there with the patient and treating the patient. We also shared the story of one physician earlier this year who was a pediatrician and had a young girl in her office as a patient, and the girl later drew a picture of the physician who she was supposed to draw a picture of her hero. So she drew a picture of the physician. And rather than the physician using a stethoscope or even giving the patient a shot, she drew the physician standing behind a computer terminal. I think that is a picture of what the practice of medicine, unfortunately, has become for so many physicians, standing at a computer terminal because they have to overcome all these administrative burdens and barriers that are put between them and the patient. We do think that there are solutions to these problems. We came this past session with some legislation, and Representative Mosier sponsored the legislation to reform prior authorization. We hope to keep working on that and perhaps talk about doing some additional legislation next year to see if we can get something passed that would relieve that burden, not just for physicians, but for patients as well. We want to continue to support physician wellness. Again, Senate Bill 12 was very helpful, and we hope to build on that. We want to maintain support for the Kentucky State Loan Repayment Program, which additional funds were added during the last budget cycle for that to try to bring and keep more physicians here in the state. And we are also looking at investing in perhaps some state-based graduate medical education for physicians. Physicians go to medical school and then they have to go through residency, and those residencies right now are funded by the federal government, and there's been a cap put on those that really hasn't expanded a lot over the years, and it's limited people coming out of medical school being able to get into those residencies. So we would like to at least explore the possibility of having some state-funded residency programs here in Kentucky to try to get more physicians trained here so that they'll stay here. 3 years ago, I would have come here to say that Kentucky badly needed more physicians, and unfortunately, the situation's only gotten worse. And we really need to work to not only bring in more physicians, but keep the ones that we already have. I think all of this, my dad would say, kind of sounds like a sad country song, but there is a country song that I think is applicable to physicians. And there was a song that was written as probably his most famous song by Waylon Jennings back in the 1970s, and it was a song that was a lament about what country music had become up to that time. And in the song, he said simply, "We need to change." For physicians, I echo that lament right now in the practice of medicine. There needs to be a change. There needs to be a change to help make people healthier, let them spend more time with the patients, and make a change so that Kentucky becomes the place where physicians want to come and practice medicine because they know that they're helping more patients. Thank you, Mr. Chairman. I'll be happy to answer questions once the
Thank you.
presentation.
Again, we're holding questions till after our third presentation, and this is a virtual presentation of Kentucky Nurses Association. You folks prepared? Are you ready?
Yes. Good morning. Can you hear me?
Yes, please proceed.
Good morning. My name is Delanor Manson. I'm the CEO for the Kentucky Nurses Association, the Kentucky Nurses Foundation, and the Kentucky Nurses Action Coalition. I've been in this position for about 7 years, and I bring to this position 27 years as a Navy captain in the United States. I want to say that on behalf of the Nurses Association, the only organization that represents every nurse in the state, that's 90,000 nurses, and it's still not enough. I want to again thank you for the opportunity. Nurses comprise 53.3% of the healthcare workforce engine, but when most people think of nurses, they think of nurses who work in hospitals. And nurses work in so many other places. Only 46% of all nurses work in hospitals. Others work in long-term care, corrections, hospice, home care, and many are independent practitioners. I appreciate the opportunity to review what the Nurses Association has done pre-pandemic, post-pandemic, and I will be quick. I will not go through everything that we have done, but we have been pretty busy. Pre-pandemic, there was a nursing shortage. The pandemic did not cause the nursing shortage. On average, the Kentucky nurse is 53 years old. Nurses in the rest of the country are 42. Things such as inflexible work schedules, unsafe workplaces, nurses being absent from decision-making in organizations, nurse retention, and the image of nursing has played a part in the nursing shortage. While the pandemic was certainly nothing that healthcare or nurses could have predicted, the Nurses Association quickly assessed the need and volunteered to address the challenge through its 11 statewide chapters. Nurses met the identified workforce management opportunities by coming together to talk about what is it that we could do to address those issues. And we did that in September of 2021. In the midst of the pandemic, KNA responded vigorously to the disasters to support the communities in need. In December, when the tornado raged Western Kentucky, KNA was there. We provided shoes, water, food, glucose monitors, blood pressure cuffs, and more. We were on the ground, climbing through the rubble and wiping away the tears. When the July 2022 flood hit Eastern Kentucky, KNA was there. We paid for licenses for every nurse in the affected area to help sustain and maintain their livelihoods, also providing clothes, food, water, and more for residents. In 2020, when the communities needed testing, KNA was there. We began collaboration with the health departments, and we provided tests in the most vulnerable areas and for the most marginalized people who did not have resources to get to testing. Beginning in November 2020, we continue to present to doing mobile testing events. We've done over 300 to 56 unique sites, and we have presented over 20,000 tests. I understand that you cannot see my PowerPoint, and that is not good. Well, let's make that happen. Okay. So in terms of testing, we tested in the most vulnerable areas. And as you can see, the squares are places where we did the testing, and the larger squares are where we did the testing in multiple. We did a lot of testing in the larger squares. Okay. We also provided listening session. We did more than 60 listening sessions, and the most important things about the listening sessions is we answered questions about those who needed to know what they needed to do to make good decisions related to just testing. We provided accurate information, and we built on the fact that most people think and trust nurses. As you well know, the Gallup poll has validated that nurses are the most trusted profession in the world, and that has been for 20 years straight. In 2020, when the vaccine came into being, we participated in staffing and recruiting volunteers for LUVAX that was in Louisville. We had people from all over the country coming to Louisville to find out how we did the very first drive-through vaccination clinic, how we staffed it, how we trained our individuals. The KNA was instrumental in training over 7,000 volunteers to include pharmacists, physicians, researchers, retired nurses, student nurses, nursing school faculty. We provided over 110 vaccines, and then we worked on providing vaccines in the community by doing mobile missions. And those mobile missions continue today. And as I know you've heard about the wind down, our last mobile missions will be at the end of June, unless we get some funding to continue. While nurses were heroes during the pandemic, we fast became zeros because we were encouraging people to get vaccines so that they would be safe and that we could save their lives. So in looking at the post-public health emergency opportunities, I hear from colleagues and patients daily that they're tired of COVID and the COVID vaccines. It is essential that I state that COVID is not dead. While the public health emergency has ended with the declaration, the CDC recommends that individuals ages 6 and older receive an updated bivalent COVID vaccine, regardless of whether they have previously completed their monovalent primary series. Only 17% of Kentuckians have received the bivalent, and which is the vaccine that can combat the current predominant COVID virus strain of Omicron. Omicron currently makes up the majority of all COVID infections. COVID is not tired of us. In Kentucky, 30 to 60 people die a week of COVID, and 1,000 a week die in the United States. One of the most effective ways to combat COVID at this point is to get a bivalent vaccine. So, where do we go from here? We need to leverage the trust that the community has in nurses and that we've earned while we participated with the COVID pandemic. We need to partner with state and local officials to develop community-centered plans to identify needs and to develop those partnerships. We need to address ongoing increasing vaccination needs. And as we heard from the Secretary, that's not just COVID, but all vaccination needs. And we need to use what we learned when we did the testing in the vaccination clinics and the success that we've had. We also need to work on the workforce shortage. It is essential. The survey that was done by the American Nurses Foundation identified that 60% of the nurses nationally state that they would plan to leave their jobs in the next 6 months. That is not what we found with the KBN survey in October of 2022. However, I think it is something that we need to be aware of, that nurses are considering leaving their jobs and the profession. Kentucky is one of the 11 states that has not received federal funding for a workforce center. And we were just in Washington last week meeting with our legislators to talk about how can Kentucky maintain and get access to workforce center funds. Nurse retention must also be a priority. I know that there's a lot of discussion about the pipeline, and that is really good. But we must do everything we can to retain the nurses that we have, as the Kentucky Medical Association has also identified. We also need to look at grants and other funding sources so that we can maintain the competence of our staff. And as I heard, the Kentucky Department of Public Health is main stockpiles of supplies. We need that as well so that we can quickly respond to a disaster or other needs. So healthcare is the engine for the economy, and nurses are the engine for healthcare. And so I want to say that at 53.3% of the healthcare workforce, there is no healthcare without nurses. And I'll take questions.
Thank you very much for your presentation. And we are almost out of time, but we've got a couple of questions. Senator Titchener, you have a question?
I do. I'll try to be brief. My question is in regards to the physicians. Of the 590 that have left, have you surveyed them as to why they left the field?
We have not. That number comes from a different survey that was done by the Office of Rural Health. But we do try to keep in touch with physicians who come out of residency in Kentucky and may go outside the state, and but all of that is very anecdotal.
Okay. And just to follow up really briefly, I have a question from a doctor who knew that this was coming on, and she just asked that I mention that employed doctors who were not able to operate and run their practices during the shutdown and everything was closed while the hospitals were empty and preparing for the pandemic onslaught. How do we make it easier for independent doctors to become independent so that they have more flexibility to be able to provide for their patients? Do you have any suggestions for that? I know that's a big question.
It is a big question, and it gets to the point of physicians being employed and why they're employed. I think that for physicians to actually go out and open a medical practice is daunting right now, especially for physicians who are coming out of residency. They have very little background and training in that, and I think they're they're kind of taught that they're going to come out and be employed. We used to do a seminar back in the day that was just called Opening a Medical Practice, and we would have 20 or 30 residents coming in to learn about doing that. We stopped doing that 8 or 10 years ago because nobody came. Nobody was doing that.
Senator Berg.
It's an amazing presentation, and honestly, I would be more than happy to sit here for the next 3 days and talk about this issue. But we won't. First of all, I want to reiterate that prior authorization, particularly for medication, is out of control. I personally had an experience last week, 3 days on the phone trying to get reauthorization for a medication that had already been authorized for a year, and then they go back and rescind the authorization. Can't even tell you why. So you don't even know what you need to present to them to get it done. It's horrible. I so respect Representative Mosier for bringing this forward, and I really, really hope we can work on this next session, because if you want to remove administrative burdens from physicians, that is a great place to start. There's something even more important that I want to relay to you and to this committee. I have had the opportunity to talk to first and second year medical students at University of Louisville, where I went to medical school. They have asked me to come and talk to them about what's happened in the session, what laws were passed, how will it impact them. And guys, this is what they're telling me. And I don't know how to respond. These first and second year medical students, and I would say there's at least 40 in the room when I'm talking, are telling me that under no circumstances are they planning on doing their residencies here in Kentucky. They are all planning on going away. They feel like it is their only way to respond to what they see as a significant legislative overreach impeding their practice of medicine. And they are planning on going to states where that does not happen. And I am not making this up. This is what they are telling me. And I'm standing in front of these classrooms trying to convince them, no, we need you here. We need you to stay here. We are going to lose more and more physicians if people in this state don't wake up and realize that they have their own ethical, moral obligations to their patients. And you can't put them in a bind where they can't practice medicine the way they think it has to be done. And I am just, this is a warning, guys, a big warning. When entire classes of medical students tell me they have no intention of staying in this state, we have got to do something.
Duly noted. Thank you. Representative Rourke.
Thank you, Chair. I briefly just wanted to circle back on what we heard at the beginning of today's meeting with the announcement of the 1915C waiver slots being full. I believe that we all understand that that's an impending crisis for our constituents, because the home and community-based waiver was our safety net for our seniors and individuals with developmental and intellectual disabilities. So I know our goal is always that we should be finding ways to have the least restrictive, most community-oriented options for them. And I look forward to, continuing that topic on the agenda for our upcoming meetings, especially as we look to what we're going to do for services for the waitlisted population between now and August. I mean, it is a long time to wait, especially since people are going to be put into systems that maybe are not so least restrictive. And they're probably going to stay there as if they get placed in a nursing home or other facility. So I'd just like to ask for the Commissioner, Veronica, Judy-Cecil, for the updated numbers of what those wait lists are currently at, so that way the committee can look into that before we meet again and hopefully address that topic. So thank you, Chair.
Thank you. And the last question comment comes from Senator Funky Frohmeyer, because it's her birthday.
Wow, thank you. No one try to guess my age. All right. I do. I find so much appreciation that you have provided us the depth of information and the engine in our nurses. Well said. I thought that was fantastic. My mom's a nurse for 54 years. Mr. Padgett, Ms. Manchin, and also Secretary Freelander, I believe in preparing your body for what was kind of the onslaught and sort of that natural battle to the COVID infection. We didn't address that at all in what was the public health department's efforts to guide people on natural approach. But then also the piece that you had shared, Delanor Manson, that the nurses also became a very trusted resource as well. Mr. Padgett, we need to change more time with the patient. So my question comes back to how then is the information offered to me, the patient, so that I really understand the vaccine injury reports, that I really understand how to make my most informed decision. We don't know the ingredients in the vaccines. So how do we accomplish that in order to make a decision of whether we get a COVID booster or whether we even get a COVID vaccine for the first time, and what difference would it make? And how does that compare with taking your own health in your own hands and be proactively healthy, knowing you might get COVID, but you can overcome it? How is that being conveyed? I didn't hear that addressed much in outcomes and results by taking your own proactive approach.
I want to start by saying that's what we did with the listening sessions, is that we went to the community, wherever the community was, whether it's where they worship, where they live, where they work. And we answered the questions that they asked. We didn't necessarily provide them with a great deal of information initially. It's what do you want to know? So when they asked those questions, those were the answers we gave them related to what's in the vaccine, how was it made, those things that were most on their minds. And we did 60 of those.
And relative to the vaccine injury report, it does seem to be unavailable in a common place that a common person might be able to find that information to make an informed decision. How do we make informed decisions today?
I would say that falls upon the CDC and the Kentucky Department of Public Health. We do review that type of information and share it, as I mentioned, when we are asked.
Thank you for the information. Appreciate it. And appreciate our presenters today. You've done an excellent job. I know you were rushing on the end, you folks, but appreciate what you bring to our committee, and we look forward to working with you. For our committee members, our next meeting will be Monday, July 24th at 1:00 p.m. Agenda will be forthcoming. Appreciate everybody's participation today. Thank you.
Thank you.